start. Good morning, everyone. We're going to wait about another 3 or 4 minutes before we start. I think there's a lot of attendees that are just joining in, so stick around. We'll start in about 3 minutes. We'll give 1 more minute as I see there's a lot of attendees trickling in, but we'll probably start in a minute. We have a jam-packed webinar, so if we want to have time for Q&A at the end, we're probably going to have to start in about a minute. Okay, well, I suggest we start. I have a few housekeeping items, so as people are trickling in, that should be all right. I'd like to welcome everyone to this lovely webinar, Understanding Juvenile Underwriting. feels like we say that every month we have a webinar, but this is a record-setting webinar. Again, we had 400 registration. I think we're at 200 plus attendees listening right now. So we're really happy to see you all and provide you some information. I have a few housekeeping items. The next webinar in October is going to be on contestable claims investigation, so more of a claims flavor. There's going to be a lot more information to come, so you'll see emails or advertisement on LinkedIn on that. I also want to note our in-person underwriting seminar that's going to be November 6th to November 8th right here in Dallas. I know a lot of you have joined before, so you're always welcome. If you do not have the information, you can always email us at info.us@optimumre.com, and then we can provide some information for you to join us in Dallas. I'm going to ask that any questions that you have throughout the webinar, you can always go into the Q&A section at the bottom of your screen. Type the question, I will monitor everything, and we have some time at the end of the presentation to go through all the questions and Q&A. If you have additional questions following the webinar, again, you can reach us at info.us@optimumre.com. I will mention that there's going to be a quick survey after the webinar. If you can please fill it out quickly. I think it's 3 or 4 questions. But the value here is really, we want to hear from you on what you would like to learn about in future webinars. So it's always good for us to know what to talk about. And without further ado, that's all my housekeeping items. I will introduce our speaker today, Dr. Minas Joannides. Dr. Joannides started in private practice in pulmonary medicine in St. Petersburg, Florida. Both his grandfathers and his father were pulmonary specialists. He worked for 3 different direct life companies before joining Optimum Re about a little bit more than a year ago, right?
Right.
And with that said, I'm giving the stage to Dr. Joannides.
Well, thank you, Jonathan. Welcome, everybody. So we're going to dive right in with juvenile underwriting. You all requested this topic. So the things I'm going to talk about today are juveniles are different, especially when we approach them from the life insurance standpoint. Today, we're going to talk about juvenile build. That's an interesting feature about juveniles when they apply for insurance. I'm going to have a pragmatic approach to medical impairments in juveniles. We'll do some case histories, and I think you'll see things today that are just not covered anywhere else. So we'll get started. So here's a couple of juveniles. Cherubic looking fellows, and they just happen to be my wife and my kids. So I did have some kids to work with during my lifetime to see how they fared during their early years. So I owe them a debt of gratitude in giving me some lab on the job training. So we'll talk about the 10 leading causes of death by age group. And this is from 2010, but it's approximately the same now. And you'll notice that for the younger ages, that's the ages are listed at the top. Age less than 1, then 1 to 4, 5 to 9. That for the early years, unintentional injury is a prime mortality risk for people in the juvenile age group. So accidents are the leading cause for most of those age groups. So you'll notice below as ranking in 2nd, 3rd, 4th that homicides and suicides, unfortunately, are also noted. So a lot of deaths in juveniles are not related to medical issues, but just due to accidents. And to highlight that, this is specifically just unintentional injury deaths, ages 0 to 19. And you'll notice that in ages 1 to 4 through 15 to 19, motor vehicle related accidents are the leading cause of death in those groups. So accidents by far are for juveniles the riskiest thing that happens. And so obviously when we underwrite, we don't usually get to be able to pick out who is at risk for motor vehicle accidents in juveniles, but that is one of the leading causes. And to the right, you'll notice a cord for the shade for the windows wrapped around the handle to open up the window. And unfortunately, for my wife, when I was working at some of the insurance companies, I used to do structured settlements, and I would tell her all about the terrible accidents that would befall some kids. So she always wrapped the shade cord around the window handle to protect them. Of course, they've all grown up and are in their 20s now. So she still does that every day. So I guess she's worried that I'm going to trip and fall into the cord. So at least she's taking a look out for me. So juvenile ratings, basically children should be standard or close to standard risks. Parents also get upset about ratings for ADHD or mild autism spectrum disorder. So you may get letters for kids that you have rated or declined for those kind of issues. And parents, however, also want to anti-select and get life insurance for kids with significant medical impairments. So, we have to be careful with the children that are applying that do have any suggestion of a significant medical impairment. Of course, it's difficult to predict the risks over a 70+ period of time if a child has a serious impairment. Often if they do have a significant impairment, it's better to reconsider them when they're an adult. So I have a little quiz for you. We're not going to actually have a way you can register your vote, but just think about it. So which one of these is not like the other? So the question is, what age group has the highest juvenile mortality risk in the US general population? Is it teenagers age 17 because of motor vehicle accidents? Is it teenagers age 13 because of motocross accidents? 10-year-olds because of bicycle accidents and sports, or newborns in the first year of life due to newborn risk? So think about that for a second. And the answer is, looking at a life table US, I've highlighted in the red boxes certain years, and these are years. If you look at the far left, you'll notice this is the age in years. So the age 0 to 1. So that 1 year period of life from 0 to 1. I've also highlighted 10 to 11 and also 59 to 58 at the bottom. And then as you work your way over in the long red boxes, you'll notice that we start with 100,000 people. And in the far right column, you'll notice the number dying between the ages of X and X plus 1. So for the first box at the top, the age between 0 and 1. So actually 659 deaths in children age 0 to 1 per 100,000 that start. Okay. You'll notice that for ages 10 to 11, the number of deaths for that year is 8. And then the number doesn't get as high as for the first year until you get into the late 50s, 57 to 58, when it goes back into the mid 600s. So you can see that the newborn age 0 to 1 is really a high risk time period. And it's kind of like an airplane taking off. If the takeoff is okay, you're probably okay once you're in the air, but you got to get started. And so the first year is the more dangerous one. So when we approach life insurance in the first years of life, we want to make sure that the insurance is in a proper ratio to the parents and the other siblings. You want to always check for the well baby visits and the growth charts and see that they're in, hopefully, at least the middle of the pack on growth charts, and that they're meeting their milestones. And the pediatrician usually notes that in the medical records if you get a pediatric APS. Things to watch out for are words like hypotonia or floppy baby, inability to turn over, inability to crawl or walk when they should be doing that, an inability to talk when they've hit certain ages. If you see feeding tubes, that's probably a red flag. And then any mention of cerebral palsy, you'd want to probably refer to your MD to take a look at. So just talking about infant mortality, serious causes of death, born with a serious birth defect or born too small or too early. Of course, kids now can be born very early, and the NICU, the neonatal intensive care, somehow pulls a lot of the very, very young kids through, but they're still at risk. Victims of sudden infant death syndrome, or SIDS, kids affected by maternal complications of pregnancy, and then victim of injuries, pardon me. So these are the top 5 leading causes of infant mortality and account for about 57% of all infant deaths, at least in 2010. This is a good article from the Journal of Insurance Medicine. And if you wait until at least 15, but better to wait till 30 days before you take applications on kids, that you probably eliminate a lot of the mortality risk, since most of the infant mortality is in the first 27 days of life, based on the study and the work that Dan Zimmerman did, and they wrote the article for the Journal of Insurance Medicine. So that's probably a pretty good place to start taking applications after 30 days. And young child, depends on what year we look at, but they have approximately a life expectancy of 78 years. But there's something wrong with this picture, right? You know, parents would recognize what the problem is here, is that the risk of SIDS is present. And so the Back to Sleep initiative was invoked to help prevent, kids from dying of SIDS and other unintentional accidents in their bed. So by going back to sleep, putting the child on their back rather than on a prone position did decrease SIDS significantly. And it was noted as far back as 1992 to 2005. There's all kinds of apnea monitors, the old apnea belt, and then now there's all kinds of gizmos to put on kids if there's any question that they might have apnea issues or any other kind of problems. You can monitor their heart rate. It can actually go to your cell phone. So there's all kinds of things and ways to monitor. So we're way ahead of where parents were a long time ago. So the life, underwriting, and CDC child development milestones at age 1 year. Kids at 1 year should be getting to standing position without help. Some kids are way ahead of that. They should be able to pull to stand or walk with holding onto furniture, say some words and wave goodbye. But if they're not able to crawl and can't stand when supported, or they can't say single words, or they lose skills that they once had, then that's something you might want to look at and note when you're underwriting the case. Today, as you well know, there's a lot of vaccinations that were not available in many years past. So kids, I know we kept track of our kids, and it was always things that the school wanted to know, is all the vaccinations that they had received. And as you can see, there's innumerable vaccinations available now. And I know some parents are always skeptical about having their kids get all the vaccinations or any, but I still highly recommend it, and most pediatricians would as well. And because in the 1950s, before the US had polio vaccines, we had a real problem with polio. And unfortunately, a lot of kids had weakness or paralysis in their lower extremities, and they had to wear braces for the rest of their life. And unfortunately, some people actually were unable to breathe well due to the weakness in their respiratory muscles. And they actually were put in these contraptions called iron lungs, which you can imagine that would be the worst place you'd want to be, lying on your back in a metal cylinder that's actually pumping to help you breathe. We didn't have ventilators back then. So polio was a huge problem in the 50s. We should be grateful to the pioneers that successfully produced vaccines, and they actually tested the vaccines on their families first to make sure they were safe. And you think you get over things like polio when you have good vaccines that we have now, but this just came out, and I got this weekend from the New York Department of Health, because I'm licensed in the state of New York. And this was a health advisory that there's a severe respiratory illness caused by both rhinoviruses and enteroviruses, two types of viruses that can cause things as simple as colds. But there's this particular enterovirus EVD68, and it actually in rare instances can cause an acute flaccid myelitis that's indistinguishable from paralytic polio. So you never know what's around the corner, and you always have to be on your toes with what illness is coming down the pike that can affect kids. And so this is something we'll be watching and see what happens. Probably before most of you were born, and maybe this helped protect you in utero, is back in the 60s, there was a major outbreak of rubella, and it affected pregnant women. And unfortunately, when women were pregnant and got rubella before there was vaccine available, children that were exposed to that virus in utero had all kinds of really bad outcomes. And it was the congenital rubella syndrome. This is a picture from an old Life magazine. And there were all kinds of heart defects and cataracts and deafness, intellectual disability. So we're lucky that we have rubella vaccine. And this is why when you see in the APSs that you see when women have gone through pregnancy, that they get tested for rubella to make sure that they're immune to rubella. So there's no possibility that their child could be exposed to this kind of a syndrome. So we're lucky those vaccines are available. By the way, Zika virus to pregnant women also can affect the babies in similar ways. So Zika is not that much different than congenital rubella syndrome. So one thing we've all been interested in the last few years is COVID vaccinations, and you basically need to consult the CDC guidelines for who's able to get what. But this I just copied out of the CDC guidelines on staying up to date with COVID boosters for kids, and they can still get the original vaccination and booster. And you probably want to consult this and speak with the pediatrician about your kids about getting COVID vaccinations. But just recently, the bivalent boosters have become available. And so I wanted to bring everybody up to date on what's going on with this, with Moderna for age 18 and up. So it really kind of is a little above our juveniles, but their vaccine is a combination of 25 micrograms of original SARS vaccine and 25 micrograms of Omicron variant. That's the BA4 and BA5, which is the latest variant that's out. So that is available now. And if you use Pfizer for ages 12 and up, the booster bivalent booster is available, and it's a slightly smaller dose. You get 15 micrograms of the original SARS and 15 micrograms of the Omicron variant. So a little less of each, but we're able to give it to kids that are younger, so ages 12 and up. So it is available now. And if you see the name COMIRNATY. That's what's also being called the original Pfizer biotech COVID vaccine. When initially COVID hit and some children were thought to have COVID and had this weird multi-system inflammatory syndrome, it was especially tracked by Mount Sinai Hospital in downtown New York. It seemed to be related to COVID. Fortunately, most of the children who were diagnosed with this have gotten better with medical care, but you still may see it mentioned in APSs or something along this line. So something to keep an eye on in kids that apply for insurance. If they just happen to have had multi-system inflammatory syndrome, you probably want to refer that to your medical director or us so that we can take a look and see how the child is progressing and see if there's any residuals. I also wanted to talk about flu shots. Can a child get their flu vaccine and a COVID vaccine at the same time? And the answer is yes. So they are eligible to get both. And of course, depending on the ages, as I described before, the kind of booster that they get depends on what their age is and what type of vaccine is being provided. But I wanted to show you this chart at the bottom of this page, which is kind of an interesting, and it's a little busy. We're going to go through it because I think you'll find it useful. So if you'll notice, way over to the right is the 2018-19. So it was that season for flu, and that's the blue or aqua line. And I've highlighted that the peak occurred in New York State. This is New York State numbers in about, February of that particular flu season. Then if you look at the 2019, which is the gray curve, 2019, 2020, the peak was a little bit sooner, but a much taller peak, but still in the late January, early February peak. So that's when most of the cases were confirmed of influenza in New York State. Then let's look at the green curve, which was when COVID hit in 2020 to 2021, right? That's the green arrow, and you'll notice that it's a flat line at the bottom. In other words, there were basically no positive influenza cases in New York in that year, which is remarkable. But everybody was staying home and wearing masks, so influenza wasn't being transmitted. It really wasn't the vaccine, the influenza vaccine, that was working so well. It was that people were taking precautions and wearing masks, so at least we weren't transmitting influenza to each other. And then you'll notice a really bizarro year last year where we had two peaks, that's really not happened before. We had a very early peak, that's the red line, in about mid-December. Then what happened? Omicron hit, everybody masked up again. So the red line went down to baseline again, almost like the green line the year before. But then when people demasked after they kind of got over the Omicron scare in April and May, we had a very late second peak. So that was kind of a bimodal year that really never happens. So the flu seasons have changed dramatically, and it's kind of adapted to how we have masked up for COVID. So it's something to be aware of. So flu vaccine is made the old-fashioned way. They grow the wild virus in eggs. We don't have mRNA type flu vaccine yet. Hopefully it'll come. And you need one chicken egg per dose. So hopefully you have healthy chickens making eggs, because we're going to need healthy eggs in order to make a dose of vaccine. At the top, I have what's mixed into the 2022-2023 flu season vaccine, and it's we get 4 valencies, so to speak. So we get 2 A's and 2 B's. So 2 influenza A's, 2 influenza B's. And these are the most likely influenza viruses that are going to cause an epidemic in 2022, so this fall and winter. To the bottom, I also added what was in last year's batch, which includes two of the same varieties, the Victoria A and the, when I first pronounced it, I was a little worried about pronouncing this in a webinar, but I looked it up and it's Phuket. And it's in Thailand. It's an island in Thailand. So Victoria A and Phuket B were in last year's. Now, last year's vaccine was a real bust. It really didn't protect very much at all. It had kind of a 16% efficiency rate of protection. So it was almost like a coin flip. Hopefully, even though we've included two of the strains from last year, we'll have a better response this year. So we'll keep our fingers crossed. We're going to switch gears a little bit now and talk about juvenile build. This is a growth chart. The CDC, has these that doctors can use to record kids' progress in growth. This is for boys. I just happened to pick out the boys age 2 to 20 years. And this is the body mass index for age in percentiles. So in red, I wrote down the 95th percentile, which is the top line. And I circled the 5th percentile, which is the bottom line. So this kind of, you track how a child, how their growth is if you were using BMI. And then at the bottom, I've circled the age in years. And over to the far left, I've circled BMI. So that's what we're using. As you'll note on the graph, that the BMI from ages 2 through ages 6 actually goes down. So if you're using some kind of calculator or some other form of calculation to check out what the BMI is and try to rate kids based on that, it's kind of interesting that the BMI is going down as they get older from age 2 to age 6. So probably for those years, it's better to use weight than it is to use BMI because it's a little confusing and you're going to get a lot of oddball results when you try to calculate BMI. Because as you'll note to the right, I've put the BMI calculations and you'll see that the problem with BMI in the younger ages, and I've highlighted it with the red arrow, is that in the denominator of BMI, the height is squared. And whenever you're squaring something, and in little or young kids, their height is actually increasing faster than their weight is at times. So that's why from ages 2 to 6, you're going to get this drop in BMI because the denominator actually becomes more powerful in the calculation. So that's why weight for the younger ages is probably a better way to go. One of the problems, of course, with juvenile build is you don't have a paramed examiner. It's usually a guess by the parent or agent or grandparent. And in the very young, a few pounds can make a big difference. So sometimes it's difficult to accurately assess the build. What I try to do is get acceptable weights between what I call the goalposts. And you probably don't want to accept kids that are way too far beyond either the minimum goalpost or the maximum goalpost. And so probably it's better to take kids that are, kind of in the middle and fit the tables that you may use. At Optimum, we use, weight for the younger kids. And it's probably better to stick pretty close to standard. You may be able to go up a bit for slightly under or slightly over, but you probably don't want to take massively obese kids because of the problems they're going to run into. And as you'll note, I've circled the years to the left of 1963-65 to the years 2017 to 2018. You'll note how in that time period that overweight has become much more problematic for kids. and many more kids fit the overweight build category. And, you know, we have a lot of reasons for that, but supersizing fast food is one of the things that has contributed to that. However, you know, back in Pompeii in 79 AD, they had fast food. Those round circles are where the food was actually put, and there was heat underneath. Fires were built. And this is actually from a picture from Pompeii. This was actually street food. So they had fast food back in very early years, but obviously kids were not obese like they are now. So we can't just blame it on fast food. It's the kind of fast food that's available, right? So it's the kind of things that kids like to eat. So what are the risks? You know, overweight, juvenile build, and health risks, cardiovascular disease, just like in adults, insulin resistant, you know, there are risks for hypertension, obstructive sleep apnea, liver abnormalities. You know, some kids are already on statins when they're very young, sometimes because of familial disease, but, you know, they're probably not helping themselves with the food that they're eating. Fatty liver disease, and actually it's a risk for cancer long-term. So I don't know if you can see the top, but this is a quote, approximate quote from Yogi Berra. He was a baseball player way before your time, but he played for the New York Yankees, and he was known for his unusual quotes that he would throw out. So I kind of moved this one into the underwriting space, and he would remark something like 90% of underwriting is 50% mental. He was always known for his unusual phrases that he would throw out. And there's a young kid standing with him during spring training that year. We're going to talk about asthma in juveniles. So a lot of times pediatricians or pulmonologists that take care of kids, they use the term reversible airway disease or reactive airway disease instead of asthma. So basically the same thing. It's the child is wheezing, and we're not sure because they're so young if it's chronic or just an acute episode. But very small children have really tiny airways, as you can see in the picture that I've put at the bottom to the left. And so when they get edema or swelling in the airway or mucus in the airway from a viral infection or whatever, like RSV or influenza or whatever the case may be, there's really very little space for the air to pass through. So that's why they have difficulty breathing. Compared to an adult, which even though they get edema and swelling of the lining of their bronchial tubes, they still have enough passageway for the air to move in and out without as much difficulty. So as the child gets older, their airways become bigger, so they're less likely to have these acute episodes. So asthma attacks tend to become less severe as the child grows older. Most of the time, there are kids that are going to, you know, continue to have severe asthma attacks. You're probably going to be able to pick those out. So, you know, if a child has had a history of status asthmaticus in the emergency room, and, you know, they just couldn't breathe, they were intubated or something like that, that's obviously a red flag. So you probably would not take them for insurance if the history was recent, or if they have frequent emergency room visits and multiple hospitalizations, another red flag. So that would be to the warning end of the spectrum that I've put here. Or they're using rescue inhalers to excess, or they've been steroid dependent on oral steroids, Medrol or prednisone, another red flag. So those are the kind of cases you probably want to avoid. But there's a lot of children that just have, you know, a mild episode, or maybe they went to the ER once, that you could still consider for life insurance. And what do we do for kids? You know, the best way to put the medicine where the problem is to nebulize it, or somehow get aerosol particles to the bronchial tree rather than taking pills. So if you can nebulize the medicine with a nebulizer, or if you look at the child at the bottom on the right, because kids have trouble squirting the inhaler at the time they breathe in, most of the time when my child that used an inhaler tried to use it, he would squirt the inhaler and then exhale, so he didn't get any of the medicine. So what you do is you use one of these spacers, and they can just hit the inhaler to give a dose into the spacer, and then just breathe from the spacer at their leisure to get the medicine down into their lungs. So works pretty good. And at home, what can kids do to keep an eye on how their breathing is? They can be followed with little peak flow monitors that are not expensive. And there's normograms to see how the child is performing at home. I don't see it a lot in APSs, but at least it is available for kids that have chronic issues or have had a history of asthma in the past, to monitor their peak flows at home. Okay, we're switching gears again, covering a lot of different topics today. So alkaline phosphatase is elevated in juveniles due to bone growth. So you're going to see some very high levels of alkaline phosphatase if, for whatever reason, the child happens to have blood work done in their juvenile years. So, I mean, you can see that some of these values are in the 600, 800, even up to 1,000. So you don't have to worry about alkaline phosphatase in a child that's elevated unless there's some other specific reason to do so. I mean, you can expect elevated alkaline phos all the way to the time that they become an adult. So not to be concerned about that. We're going to talk about the autism spectrum disorders. It is a spectrum, and that's how it's classified now. So where does the child fit in terms of the spectrum? Are they on the mild end, intermediate, or severe? And do they have difficulties in social interaction, verbal and nonverbal communication, and repetitive behaviors? Is it really severe with autism per se, with seizure disorder and all kinds of other things that may be related? Or is it on the mild side and the child has Asperger's syndrome, which I would classify most of the time as on the mild end of the autism spectrum of disorders. So it's worth taking a close look and seeing where the child falls, and we can still take kids for insurance that are on the mild end of the spectrum. So again, with the spectrum, green being on the mild side, if they have mild symptoms, Asperger's, they're doing well in school, they don't have any other problems, no psychiatric issues, no other things going on, they're probably candidates for life insurance. If they have more worrisome signs with profound disease, they're just unable to function in society, have epilepsy along with their autism, that's a much more worrisome situation, and unlikely that you're going to be considering them. To talk about ADHD, you see many, not only kids, but adults we see in insurance business where people take stimulants to help them with their ADHD. And there are two types: methylphenidate, which is the Ritalin, Concerta type formulations, and amphetamine, which is Adderall, Vyvanse, and other formulations along that line. So these are the two likely groups that are going to be chosen. Medications may depress the appetite, so that the child may be on the light side, so I don't get too concerned. Most kids are functioning well and doing okay. Again, if they have some other major issues along with their ADHD, they may be more risky. But a lot of kids can end up functioning very well, and they may use the medication for a while and then discontinue it. By the way, a lot of these medications now are in the long-acting variety. So hopefully, one dose a day can take care of the job. One thing you may not have heard much about, but you're probably going to see this on a Friday afternoon at 4:30 after everybody else has stopped working. It's a Chiari malformation. So what does that mean? And it may be described as Chiari 1 or Chiari 2, like an Arnold Chiari is also another name that the purists ascribe to Chiari 2. And this is a part of the cerebellum that may be in a place where you didn't expect it to be. And it may show up incidentally on a brain MRI or CT scan. And it's a downward displacement of the cerebellar tonsil. I'm going to show you what that is. And a lot of these do not carry any additional life risk, the Chiari ones that are just incidentally found. However, if there's associated symptoms, so if the child or person presents with, headaches that are severe or some other problems with weakness in their upper extremities, or there's other findings that are related to some kind of neurological process, and they have Chiari malformation, that's concerning, and you probably want to refer that to the MD. Chiari 2 or Arnold Chiari malformation is more severe and is associated with symptoms which may be very significant and may require surgery, and may also be associated with what's called syringomyelia, or a sac in the spinal cord, may be associated with hydrocephalus or spina bifida. So the more severe, the Chiari 2 or Arnold Chiari malformations obviously are much more worrisome and need to be looked at very closely. But the Chiari 1, when found incidentally, maybe we may be able to consider for life insurance in children. So what does it actually look like? So a Chiari 1 malformation, if you'll notice on the left, that's a normal brain, looking at it from the side with the spinal cord. And you'll notice in back, the thing that looks like a yellow or gold cauliflower, that's the cerebellum. And then if you look to the right, that little piece of yellow that's sticking down, that's called the cerebellar tonsil. And it's just sticking down a little bit where it normally wouldn't belong. So that's what a Chiari 1 malformation looks like. And that's just a minor change or a minor finding. As I said, often found incidentally without symptoms. But if the child had symptoms, then that would be worrisome and you'd need to really check on that closely. So what is a more worrisome Chiari malformation? That would be the picture to the right, where the cerebellum, you see the red area of the tonsil of the cerebellum is sticking down in the hole, which is called the foramen magnum. So it's herniated below where it should be. And then you'll notice that in the spinal cord, that blue lake is a syrinx, or that's called syringomyelia. And the combination of the cerebellum tonsil sticking down and this syringomyelia is a worrisome complication, and this particular child would need surgery likely, and not a candidate for life insurance. Okay, we're going to talk now about kids with psoriasis. I don't know if you knew that kids do get psoriasis, but they do, and they should head to the beach, because the sun and the seawater, if you're close to the ocean, can actually be helpful. You don't want the kids to get sunburned, so you protect them against that. But areas of the skin that have psoriasis, and in kids, they can get what's called guttate psoriasis, which is the Latin word for drop. Because as you see to the child to the far right, it looks like he has drops on his back. That's what we would call guttate psoriasis. And it can occur after an infection like strep. We're not sure why, but it can occur that way. It can occur just as one patch, like the picture in the middle where there's just one patch on the back that's red, and it can be confusing because it looks like ringworm. And that's what I thought my child had, and unfortunately did not respond to antifungal medicine. And the dermatologist told me I was not too bright for trying to eradicate it with antifungal medicine when he said it was guttate psoriasis. So psoriasis also affects the knees and the elbows, and so it's not atypical to see those areas affected as well. So what do you do for psoriasis in kids? You don't want to give them those powerful immunomodulator medications at a really young age. So, we took our child to the dermatologist, and he had the little light box to the right to provide UVB light for psoriasis, which was kind of a drag because you had to drive there 2 or 3 times a week. And it was a 40-minute car ride, 20 minutes each way, $100, $120 a treatment. So I said, isn't there some alternative to this little, and he had the little light box. He said, well, you can buy, and your insurance will help cover a light source. So I said, go big and go home. So I got the, which still stands in our basement, although my son doesn't use it anymore. So whenever we have workmen come through and work somewhere in the basement, they always wonder what I'm doing down there with this light box. But anyway, what is UVB light? So it's light right between 280 and 315 nanometers. So it's below in the electromagnetic spectrum, below visible light. And it's right at a specific wavelength, and it seems to work well on psoriasis, but you don't get the UVA light that's more likely to produce, skin cancer. So it's kind of right at the right point where it can provide some benefit. And just for your knowledge, in Europe, people can actually go to the Dead Sea in Israel on some insurance plans to get treatment. The Dead Sea is the lowest spot on Earth, and it has a particular combination of electrolytes in the water, and it seems to work very well on psoriasis. So people can actually go there for psoriasis treatment to jump in, and you float because of the composition of the salts in the water in the Dead Sea. It's called balneotherapy, if you ever see that. So I put a picture of where the Dead Sea is in Israel. One other feature of ocean water people may not be aware of is that it actually can kill toenail fungus. So obviously you don't want to give kids strong, potent medications for toenail fungus. And actually the combination of the salts in the water of oceans seems to have a negative effect on fungus that affects the toenail. So I actually try it myself, and it actually works. So every summer, my toenail that has fungus gets better. Probably too much information, but anyway, it helps. So I'm going to talk about a few other topics while we still have a little time left, and one of them is phenylketonuria, or PKU. All kids now, when they're born in the US, and probably I assume Canada as well, get tested for PKU. It's a inborn error of metabolism, and it's easy to test for. So what happens with kids that have PKU? Well, they get put on particular diets, as do adults, and people can live a normal life by avoiding things that are rich in phenylalanine, which is the problematic substance that can cause problems in people with PKU. And as you've noted on diet drinks like Diet Coke here, they contain aspartame as the sweetener, and aspartame releases phenylalanine when it's digested. So people that have PKU should not be using anything that has aspartame in it as a sweetener. So that's one of the things you would obviously avoid, as well as these high protein containing foods. But we can accept most applicants with PKU who are doing well following the diet. We did have a question that was submitted before I finished working on the talk, and it was about what do we do with a large baby born with hypoglycemia? So what's a large baby? So a super large baby would be one that is larger than 9 pounds, 15 ounces. So that's a big baby. And big babies are often born to mothers with diabetes and are at higher risk and should be monitored closely. And anytime a child is born with hypoglycemia, because they test sugar levels, they're at risk of problems from damage due to hypoglycemia. So they have to be treated appropriately. So probably when kids, it may not be in our manual yet, but we're going to address that you should keep an eye on these kids for a while to make sure that they're going to do just fine. They probably will, but it's good to not take them immediately, but see how they do over time because of the risks of the hypoglycemia and knowing, what the cause may have been. The mother may have had diabetes, and that may be the reason for the large baby size. One of my favorite topics, Lyme disease in juveniles. I live in Westchester County, New York, and we have deer ticks everywhere. I have deer that just love to live on my front lawn. Can't get rid of them. And if you have a dog in Westchester County, somebody in the house is going to get Lyme disease because they drag in the deer ticks, and there you go. So the trouble with juveniles is less than 50% are going to have a known tick bite. If they're rolling around out in the grass, you're never going to know if they had a tick and they had a bite. And only 15% of juveniles may have the typical bullseye rash of erythema migrans. So it's difficult to make a diagnosis. And even when you do the antigen test, it's hard to figure out if the child really even if they have symptoms that might be related to Lyme disease, it's hard to figure out if they really have Lyme disease or not. One thing that some doctors do in Westchester County and the surrounding areas is they actually, when people are healthy, they get one of those antigen screens for all the different antigens for Lyme disease when you're healthy, so that when you have symptoms that might be related to Lyme disease in the future, you can compare the results and see if the antigen levels have actually gone up, because those antigen study levels, as you know, when you look at an APS, are super confusing and hard to figure out. But if you have somebody, you've made the diagnosis. For kids less than 8 years old, you want to give oral amoxicillin twice daily for 2 to 4 weeks. Doxycycline, which is a tetracycline, is not recommended because it'll damage the teeth, stain the teeth. So you wait for older kids in order to treat with doxycycline. And, most cases of Lyme disease can be accepted even if the treatment is currently going on. As I say, you're more likely to die in a car accident driving to pick up the prescription than you are to die from Lyme disease. So although, there are reported cases of severe Lyme disease, they're pretty few and far between. So you can likely accept people that have Lyme disease unless they have some unusual problem secondary to that. I wanted to, before we finish up today, talk about cancer mortality in children. Let's say you Google the type of childhood cancer in a 10-year-old, and it said that the 5-year survival is 95%, which sounds really good, right? I mean, if you look that up, sounds very favorable. So what would that mean? That would mean that over a 5-year period, that only 5 of the children of 100 would die, right? So 5 per 100, which would be 50 per 1,000. That would be 500 per 10,000, or 5,000 per 100,000. Okay, so 5,000 per 100,000. But remember when we started the talk and I showed you at 10 years old how many kids we expect to die in the 10th to the 11th year? It was, for that 1 year, it was only 8 children per 100,000. So I know that's just 1 year, but if we had an actuary multiply all this out for us on what the risk is, you can see that even though a 5-year survival of 95% sounds great. That's still a lot more death than we would expect for a 10-year-old child over the next several years, 5 years. So you have to be careful with, cancer mortality in kids. And there may be secondary issues related to cancer due to the treatment that they may have received. There may be late effects of radiation or chemo. They may be at risk of a second primary. And, it wouldn't be unusual for a childhood cancer survivor to develop a subsequent malignant neoplasm. So they need to be followed up long-term, and that's not likely something that we see because, they probably get lost to follow up regarding their childhood cancer, and now they're going to a family practitioner for just regular medical care. I don't have very long left, but one of my favorite topics is bats and rabies, because everybody in Westchester County has a bat story. They get into virtually everywhere. Be surprised how many can get into the exhaust pipe of your dryer that goes to the exterior of your house, and they can sneak into your house through the smallest cracks. If you have a child in the house and you find a bat in the room, so that it's an unintended child exposed to a bat, which may have been bitten, they really need to get the prophylaxis just to make sure that they haven't received a bat bite that may have been, the bat may be rabid. And just as a general rule, you don't want your kids cleaning up garbage cans that have been tipped over. If you put the garbage out and there's garbage strewn on your front yard, you don't want them exposed to anything that might be related to rabid wild animals. So probably not a good idea to send the kids out to pick up after the animals have messed up the garbage in the front. And what I use is 45 days after exposure or any question of exposure. If anyone has survived 45 days after a questionable exposure, they're probably good to go. So 45 days is probably a pretty good time frame. Also, kids should avoid roadkill because like armadillos are a source of leprosy. And in Texas, Louisiana, Mississippi, Alabama, Florida, armadillos are one of the sources of leprosy, especially along I-10. So I have a long story to talk about armadillos and leprosy, but we don't have time for it today. And nobody really wants to hear it, and I would put you to sleep, I'm sure. So I won't say any more about that. So quickly, healthy 3-year-old has an alkaline phosphatase of 540. All the other lab tests are normal. What would we do? Well, we said, kids can have very elevated alkaline phosphatase, right? So we don't have to postpone. That's just normal, right? Here's our chart. So that's no sweat. We declined a 6-year-old for asthma history, but really the agent appealed this decision and has noted that although they had one hospitalization at age 3 months, 6 years ago, the doctor has said that the child is healthy with no respiratory problems and otherwise normal on growth charts and hitting all their milestones. So they're probably just fine. So, unless the child is currently having problems, I try to be as liberal as I can that, they're probably able to get insurance unless there's some really major obstacle to doing that. So as long as the kid is doing well, it's something that we can usually consider if they're much better, much improved from their asthma standpoint. And the last case that I have, I think, is 13-year-old child was playing field hockey and was struck in the head by a hockey stick. And she had an MRI of the brain to rule out brain trauma. No subdural hematoma or other traumatic injury was noted. So a Chiari-1 malformation was noted. So should we be concerned about this? Well, as I said, a lot of these are just incidental. So this is probably just something incidentally found on the study and not something that we have to worry about. So we can probably take this, unless there's really significant symptoms related to something we might worry about with a malformation like this, they're probably going to be okay. So I'm going to stop here and turn it back over to Jonathan for any questions that might have arrived.
Yeah, thank you, Dr. Joannides. That was a lot of great information. We have a few questions. Number one, your thoughts, doctor, in the case of Crohn's disease regarding mortality for a less than 16-year-old.
Wow, that is a good question, and unfortunately, I'm not prepared to answer that one, so I'm going to have to do some research on that one. But I will look it up and provide an answer. So if we can.
Yeah, let's do that. Another question. Most of the insurance applications do not focus on current schooling status for young children. Do you think adding a basic question like what is the grade the child is currently attending, would that offer some reinsurance when assessing risk on juvenile lives, like learning disabilities, developmental delays, cognitive delays, etc.?
I'm not sure asking that particular question. I agree, it is hard, especially as I said, we get little information sometimes. So, it's hard to screen out, but it would be nice to ask that, but I'm not sure that we're going to be able to do that. So I'm not sure asking that question would be helpful, but I'll find out if anyone's asking questions like that. How's that?
Perfect. This is anecdotal, but we saw a 10-year-old child with a prescription for, pardon me, I'm an actuary, so I'm going to try this, naltrexone, N-A-L-T-E, T-R-E-X-O-N-E. Do you know what that might be for?
Yeah, that's that's a drug that it's being used by some doctors, what we call off-label. Meaning that they're using it for things that we're not exactly sure why they're using it. If it's related to recovery from addiction, I can give you a good answer of what may be the case. But some doctors are using small doses for other things, and it gets really tricky. So that's going to be a kind of a case that you're definitely going to want to refer to us or your medical director or somebody to try to figure that one out, because that's going to be a toughie to extract the information you're going to need to make your decision.
Great. Another one, life insurance for children born with one functioning kidney. How long to wait before applying?
So if they only were born with one kidney and things are going well, people can do very well with one good functioning kidney if the kidney is doing well. We see a lot of kids that have trouble with hydronephrosis early in their life, and they may have to get stents and things like that. I was going to include that in the talk, but it kind of got much more detailed and I kind of ran out of time. But if some child just has one kidney, but otherwise everything is normal and the kidney seems to be functioning well, we don't get concerned about that.
Okay, two more quick one. How would you handle juveniles with fetal alcohol syndrome? It seems that there's not a lot of manuals out there that address the condition.
Yeah, that's definitely, I would wait till they're an adult and maybe consider them after they're 18 years old. It's just too difficult to try to tease out, what the problems might be. And unless you have a long track record that they're hitting all their milestones, throughout their juvenile years, I'd be very cautious about those kind of cases.
Great. And then we have a significant family history like CRC, and again, I'm an actuary, so I don't know what that means. And I'm guessing breast ovarian cancer on a female child. What is your take on when underwriting juvenile lives and significant immediate family member diagnosed with DM, CRC, breast ovarian cancer, and neurological disorders like ALS, Parkinson, etc.
So kind of an adverse family history, which I guess is becoming more of a concern, especially maybe in Canada with the ability to use family history. But, at least we can use it now. And, it's something to look at very closely. I gave a talk on breast cancer and talked a lot about BRCA and how that relates to risk. And I always want to look very closely at, family history, especially strong family history, because, that is one of the features that if a lot of members of the family, first degree relatives have a particular disease, it's likely that the child will also have it. This is especially in terms of breast, ovarian, and prostate, but, many others. So, I get concerned. Can I give you right now, like what rating or how would I apply ratings or whether I would take or not take? It's pretty specific and individual to each case, but we're always happy to help if you have a complex case like that. We'd love to, give our best advice if you could send us the case and let us take a look.
Great. So we'll come back on that Crohn's disease question. I know that down. I know who it comes from, so we can address that after a little bit more research. Thank you, Dr. Joannides. That was, again, coming from an actuary, a wealth of information. So I learned a lot. And thanks for everyone joining us. Don't forget the next webinar in October is going to be on claim investigation. Contestable claim investigation, and our on-site underwriting seminar November 6th to November 8th. Don't forget there's going to be a quick survey coming up right after this, and I would suggest that everybody follow us on LinkedIn, Optimum Life Reinsurance, to get all the news on the latest and the best. So thanks everyone, and I hope you have a great day. See you guys.